Hi, this is Paula Sherwood. I'm at the University of Pittsburgh School of Nursing, and we're going to be talking today about helping to care. And my background is all in neuroscience, so I've had a long time doing this. I've worked on the clinical floor, taking care of people with brain tumors. And right now what I do is research that looks at different ways that we can help family caregivers. And that's what I'm here to talk to you about today. And so we're going to start this webinar, and I hope that you get some good points out of it. As a presenter, I do not have any conflict of interest relating to this educational activity. So to give you a little bit of background about family caregivers in the United States, there are about 42 million family caregivers, so 42 million people that are taking care of someone who has a chronic illness. And that includes a wide variety of chronic illnesses, such as dementia, cancer, stroke, traumatic brain injury. Probably the most widely studied is family caregivers of dementia. But when you look at it, there are actually more family caregivers than there are professional caregivers, meaning that the majority of care that's being delivered to patients in the United States is being delivered by family members. Family members spend a wide variety of time. They can spend an hour a week. They could spend up to 40 hours a week. And that time is really spent doing a lot of different things. They help with activities of daily living, things like bathing and turning, to instrumental activities of daily living, such as going shopping for someone, driving them to doctor's appointments. And that time can even include providing emotional support. And those are things like helping to treat the patient's depression, simply spending time with the patient to prevent loneliness. And the costs of providing care in the United States are astronomical. And a lot of this has to do with the fact that there's a huge shift from providing care in the hospital to providing care in the home. If you look particularly in oncology, which is where we are right now, a lot of the chemos, which, you know, before you used to go in to get chemo and you would sit there, you'd go into the hospital or into the chemo clinic and you'd sit there for 3 hours and get your chemo, but then they'd watch you for another 4 hours and so on and so forth. Well, now a lot of those chemotherapies are in oral medication form, or they're still in IV form, but they're being delivered in the home. So there are a lot of costs of providing care. Some of those costs are out-of-pocket costs. So I just went to a seminar where someone talked about their father having colon cancer, and they paid $15,000 out of pocket for chemotherapy for 1 month's supply of chemotherapy. So there are a lot of drugs that are either incredibly expensive or the copays are incredibly expensive. And there are other costs of providing care that we don't typically think of, and those costs include things like missed time from work or having to take time off work, or being at work and not really being at work. So thinking of all the things that you have to do when you get home or on the way home in order to provide care. And those are costs of providing care as well. So one thing that has become increasingly studied over about the past 30 years is this thing called caregiver burden. And caregiver burden, if you're not familiar with the term, is a term that is used to describe distress. So it's how stressed out are you as a family caregiver. and it's measured in a lot of different ways. Providing care has an impact on your schedule. It has an impact on your self-esteem, your finances, feelings of abandonment. A lot of people say that when they provide care, the family disappears. And then I have impact on self-esteem down here twice. Excuse me for that. It should be impact on health. And what they found is that the stress from providing care actually affects caregivers' physical health. There's a landmark study done in 1999 that showed that caregivers that were stressed out actually had higher rates of mortality. And that was after you controlled for everything like whether or not they had coronary artery disease or high blood sugar or any of those comorbid conditions. It was the stress of providing care that caused these higher mortality rates. Since then, we've found out that family caregivers are at risk for coronary artery disease. They're at risk for altered immune status and a whole bunch of things that I believe I have a slide on coming up. So before we look at the physical stress, let's look at the emotional stress and see what providing care does. Providing care to someone with a chronic illness can cause a host of emotional problems. And the first one, and probably the most prevalent one, is depression. And there are a lot of caregivers there are a lot of caregivers that go untreated for depression. But then there's a subgroup who seek therapy or are on medication for depression because providing care is so stressful. There are really high levels of anxiety, especially in our group, in terms of not knowing. So the diagnosis comes on so fast, and then the treatment options are, you have one treatment option at one place, another treatment option at another place. You don't know how to figure out which treatment option is the best, and that causes a lot of anxiety. People have referred to problems with emotional distress, as well as stress and burnout. And burnout is just absolutely, I give up. I can't do this anymore. I can't provide care anymore. I'm completely gone. Now, why do we care about this? Well, we care about this because if you become stressed from providing care, then you're more likely to have physical health problems. So people have shown that caregivers have longer days of, they have a higher incidence of upper respiratory illness. When they do get sick, they stay sick longer. Higher incidence of coronary artery disease and blood glucose. They have a poor immune response, which means that they're more susceptible to catching colds and fevers and different things like that. People have even gone to the point of testing how caregivers respond to vaccines, and caregivers can't mount as effective an antibody response to vaccines as non-caregivers do. And like I said, there was the landmark study that talked about increased mortality in family caregivers. So before we talk about identifying caregivers at risk, why do we care? So, obviously we care because we're caring people and we want everyone to go through this experience as well as possible. But we care for two other particular reasons. And one of those is at some point the care situation is going to be over. So the caregiver is going to be at a point where they're no longer providing care. Now, if those caregivers have developed all of these health problems all of a sudden now we have a new patient population. We have people that have comorbid conditions that never had comorbid conditions before. And then the other problem is that if we have caregivers that are sick, they can't provide good care at home, high quality care at home. And we've already said that there are more family caregivers than there are healthcare providers. So if the family caregiver gets sick, we're kind of at a loss as to who's going to provide care in the home, who's going to take care of things. So how do we identify who's going to be stressed out and who's not? Because, believe it or not, there are groups of caregivers, and our research has shown that about half of the caregivers are going to become really stressed out, and the other half are not. Now, that doesn't mean that the other half are not going to be stressed. It just means that they're not going to have really high anxiety and depression and physical problems like the lower half does. So there are risk factors for being a caregiver that's likely to have these problems, these emotional and physical health problems. And we can take a look at a couple of these risk factors. The first is responsibility. Caregivers that have a lot of responsibility are more at risk, and this makes sense. So it's those caregivers whose families aren't around, who don't have a lot of help, who don't have someone who can kind of pick up the slack or can take care of other things while they're taking care of the care recipient. And then there are some caregivers, too, where the families just can't handle how the care recipient is acting. So a lot of our care recipients have problems with emotional lability, so they'll laugh at inappropriate things or cry at inappropriate things or have problems with short-term memory or sometimes even hallucinate or get physically violent or verbally abusive. And there are not a lot of people that can handle this well, and there are not a lot of people that can handle it, period, especially if it's someone that you've grown up with and have a great deal of respect for. So we look at the responsibility. You can also look at responsibility in terms of number of hours. So is this family caregiver someone who is, say, perhaps not working, no young children in the house, has or is able to make time to take the care recipient to medical or doctor's appointments? That caregiver is going to be at a much lower risk than someone who has a great deal of responsibility. You know, we see a lot of people come in at a fairly young age, and it's not uncommon that there are small children in the house, sometimes even on the way, and the caregivers typically must maintain full-time employment in order to provide insurance for the care recipient. And so you got a full-time job, you got full-time kids, and now you're a full-time caregiver. And these folks are some of the people that are at risk. There are risk screening tools for caregivers, and I kind of have this down as 2 bullet points, and I just want to make a point about saying this. There's been nothing that's been developed within neuro-oncology. So all the risk screening and all the tools that have been developed for family caregivers have been developed out of other patient populations, some in cancer, some in dementia. The problem with that is that we have our own unique set of problems. We don't follow the problems of people that have dementia or the people that have cancer. We kind of have a combination of both. And those tools that are out there, while they can be handy, are not necessarily meant for us. So you just have to be a little bit careful if you're going to use a risk screening tool. Probably one of the best ones is promoted by the National Cancer Institute, and that's called the distress thermometer, where you basically just ask the family caregiver, how stressed out are you on a scale of 0 to 10? And then that's where you can identify those family caregivers that are at risk. So for the rest of the time that we have together, what I wanted to do is talk about some of the common symptoms that family caregivers have to deal with. And I want to tell you a little bit about how we got to the symptoms that we chose for this presentation. As I said, I do all my research in the area of family caregiving, and in that we did in-depth interviews with about 101 caregivers and said basically what stresses you out. It was not a big fancy multi-questionnaire interview. It was what stresses you out, what is hard for you to deal with. And we went through and we identified any symptoms that caregivers thought they had problems with. And we found that there were really a top 31 sets of caregivers, and I can go through what those were. And we're going to talk about the top 4. But there were 31 that people said, you know what, these are really the ones that I have the most trouble with, I get the least amount of help with, and are the ones that really stress me out. And I'm going to ask your indulgence for a moment, because what I'd like to do is share with you what those topics are so that you know. We had caregivers tell us that the things that, and these are in alphabetical order, not in order of importance, but the things that stressed them out were the care recipient's appearance, the appetite, blood clots or abnormal bleeding, bowel problems, and that included things like constipation and diarrhea, as well as incontinence and toileting issues. Changes in disease status, and this could be recurrence, or it could be finding out that the tumor is gone, or it could be that finding out that you have some radiation necrosis. If it was anything that caused a change. Changes in the relationship with your loved one. The caregivers had a lot of problems with how that relationship changed, and a lot of those changes were based on how the care recipient was behaving. And some caregivers say to us, well, it feels like this is a new person, like this isn't the person I married, or this really doesn't act like my dad. Changes in vision, communicating with family and friends, and that was a big one. When this diagnosis hits, at the very outset, you have all these people kind of surrounding you, most people do, saying, oh, I want to be helpful, and what can I do? Just tell me what to do. And caregivers said, I need help, but I can't tell you what I need. We had one caregiver say, I wish someone would just come mow the lawn once a week. Caregivers feel very reticent about asking for help. So if there are things that can be just normally done, sometimes that's a better approach. Let's see, also included was not only driving the care recipient to doctor's appointments, that usually the caregiver wants to go, but little things like driving the kids to soccer practice or going grocery shopping, things like that. So we have a whole set of family and friends that want to help, but then again, we have a whole set of caregivers that need help but don't know how to ask for it. Communicating with healthcare providers, and this was also a really dicey one. We had caregivers tell us that they couldn't communicate with healthcare providers, that they didn't understand the language that was used, that they didn't have enough time, they didn't get their questions answered. One real common thing that caregivers say is that the caregiver may be dealing with a whole host of things at home, like nausea and vomiting or toileting issues or appetite. But when you get in there and you have your 15 or 20-minute visit with your healthcare provider, they felt that all of that visit should be focused on disease progression and what can we do in order to make sure that we're treating the tumor most aggressively or the way we want to. And there was very little time left for caregivers to say, hey, I need help with nausea and vomiting, or I need help with these vision changes or with these behavior changes. I don't know what to do. Caregivers talked about having problems with the care recipient's difficulty speaking. Care recipients also talked a lot about their emotional health as a caregiver, and they were, again, a little bit reticent to do this because they felt like all the attention should be paid to the care recipient. And when I say care recipient, I should have said this at the beginning of the webinar, but I mean the patient. But they don't, a lot of caregivers said, you know, focus on him or her, you know, don't focus on me. But when we got them to open up, they said, you know, I'm really struggling with this. I don't feel like I have a lot of people to talk to or a lot of time to go and talk to people. So that's when we found a lot of depression, a lot of anxiety, a lot of feelings of burden. Caregivers talked about problems with employee benefits, work-related concerns, and insurance issues, and we'll go through those. But the benefits part of it was, a lot of it was centered around getting medication or treatment paid for, getting other things paid for, work-related concerns, as I said before, not only missing work, but when you're at work, decreased productivity because you're concentrating on what you have to do for the patient rather than what you're supposed to be doing at work. And then insurance issues, the multitude of paperwork that you have to fill out, the number of people that you have to fight with just to accomplish a simple goal like getting a bed, getting a hospital bed in the home, or getting a wheelchair, or having bars installed in the bathroom. So caregivers also talked about problems with the patient's fatigue. They talked about financial, legal, and advanced planning issues. A lot of the caregivers that we talked to said, you know, I had no idea what was going on with the money in our house. You know, he always took care of it. So, or it was never considered any of my business. So, you know, here I am walking around finding these accounts everywhere. And so caregivers talked a lot about having problems figuring out where the money was, what the care recipient wanted done with the money, and trying to figure out how to manage everything all at once. Let's see. Advanced planning issues were difficult, particularly if the patient had already had problems with changes in personality, and the caregivers really didn't have any idea what the patient wanted in terms of advanced care planning. Caregivers talked about difficulty finding and obtaining community services and resources. Sometimes we heard that caregivers say the resources are out there, but they're really kind of crummy and they don't fit our needs, or they have resources out there like adult daycare, but they don't provide care for people that have behavioral issues. So that was difficult as well. Caregivers talked about trying to manage headaches or other types of pain, the use of hospice as a resource, and overwhelmingly, the caregivers that we spoke with said that hospice was a wonderful resource, that when they had hospice there, they finally felt like they were talking to providers that understood where they were and could help them solve some of the issues that they were having. Caregivers talked about medications and side effects, in particular Decadron and some of the anticonvulsants that they had. How do you deal with the puffiness? How do you deal with the kind of steroid rage? How do you deal with the increased appetite that comes along with the steroids? That was considered to be difficult. Muscle weakness, nausea and vomiting, which we'll get into here in a little bit. Nutrition, going along with appetite. Nutrition was something that was described as being difficult. Some of that centered on the anti-cancer diets that are out there. So it seems like everywhere you turn around, there's a new anti-cancer diet or a new list of things that you're supposed to eat or not supposed to eat. And with neuro-oncology being a cancer that does not receive a lot of attention, there's not a lot of information out there about how you should structure your diet in order to give you the best chance of building up your immune system and fighting off the cancer. Caregivers talked about palliative care. And one of the things about palliative care that was clear is that they didn't see the difference between palliative care and end-of-life care. So end-of-life care being that care that's delivered when the care recipient is expected to pass away, versus palliative care, which some people say should happen at the point of diagnosis and concentrate on symptom management and making life easier for the caregiver. Excuse me. Caregivers talked about physical health as a caregiver, not being able to get out and do the same kind of physical activity that they used to do. They talked a lot about safety issues, anything from physical safety in terms of worrying about the patients getting up and walking to the bathroom, to other kinds of safety issues, such as not feeling comfortable anymore leaving the children at home with the care recipient. They talked about seizures. This was quite distressing for them. Some of it was about the medication that the patients were on and trying to keep the blood levels right, trying to keep multiple seizure medications at the right dosage, and some of the concerns were simply that it's so traumatic to watch someone have a seizure, particularly if it's a grand mal seizure, where they're at risk for injury and it could happen anytime. And so when these things happened in public and in particular, that was distressing for caregivers. So they talked about sensation, loss of feeling, numbness, and tingling, what that did to them in terms of being able to, what that did to the patient in terms of being able to do simple things like button a blouse or feed themselves. Shortness of breath, skin changes, and those were particularly the ones that went along with some of the medications like the Decadron and the anticonvulsants. Sleep problems, spiritual issues, talking with children or grandchildren. And caregivers had a lot of problems talking, in particular with children, about what was going on with, and this was usually a female caregiver talking about how do I explain this to my kids that this is going on with their father. What words do I use? What approach do I use? Should I tell them? Should I not tell them? How much should I tell them? How much are they ready to learn? And we had a lot of questions about that. And the thinking, behavior, personality, which we'll talk about. And then finally, treatment options. And again, we talked about in this webinar the fact that a lot of people have a lot of different opinions when it comes to neuro-oncology. And so we have, you go to one doctor and receive one set of advice. You go to another doctor, you receive another set of advice. You go, heaven forbid, you go on the web and you receive multiple different advices, usually very few of which are anywhere near what you need to have. And who do you trust? Who do you listen to? And then on top of that, once you trust them and you try it and it doesn't work, if it doesn't work, then how guilty you feel. Well, we should have done this, and I made a bad decision, and you know, this is my fault that the tumor didn't respond the way that we thought it should respond. So there were a lot of things that were distressing about treatment options. You know, even to the point of going to a major medical center. Most people believed in going to a major medical center, and I won't name them. Probably got in trouble for naming Decadron, but there's a lot of major medical centers around, and you know, how do you get there? How do you pay for it? Let's say you want to go to one that's in, say, Texas or in Boston or in Maryland. You know, how do you pay for the flight and the hotel? Those are pretty expensive trips, and so how do you pay for that, and then do you stay there and get the treatment, or do you go home and get the treatment and then go back for a checkup? Those were a lot of the questions that our caregivers had. So that's kind of an overview of what caregivers are worried about in neuro-oncology, as far as we could tell. And what I've done is pick the top 4 most distressing symptoms that caregivers talked about. And I'd like to go through them and just share with you a little bit about what you can do for them and how you can help them. And the first is changes in your loved one's thinking, behavior, and personality. So, as I said, you know, caregivers have described this in a lot of different ways. Excuse me, I'm just going to take a small drink here. Thank you. Caregivers have said, you know, he's not the man that he was before. He's not the person that he was before. I think one of the most striking quotes that was ever said to me, and this was 20 years ago from some research we were doing, and I still remember it. It was a woman, and she said, you know, I'm just not used to him hitting me. He wasn't very good at it, so I never got hurt, but I never got used to it. And that describes a lot, I think, about how caregivers feel about these changes. Caregivers feel like they have to finish the care recipient's sentence, that the personality has completely changed. They've gone from this person that was taking it easy and would take things as they came to someone who was very anxious, very angry, and that can cause a lot of problems. There are multiple causes for problems with thinking, behavior, and personality. And you can start with the original surgery or the tumor. So it can be the result of the tumor. It could be from pressure on other sides of the brain, swelling in the brain, side effects of treatment, and other factors. If we look at the tumor, it could be the location of the tumor. Certainly, tumors in the frontal lobe are going to cause a lot of problems with thinking, behavior, and personality. It could be the type of tumor and the grade, so how fast it's growing and how big it's getting. It could be a side effect of treatment. So radiation therapy can cause some delayed reactions and long-term effects, and that can result in problems with thinking and mood. Some of those delayed reactions include mental slowing, so the person just mentally is slower than they were before. Poor attention, problems with concentration, and difficulty multitasking. And sometimes that's not noticed for 6 months to 2 years after the completion of treatment. Steroids can have, as we discussed before, possible side effects: mood swings, depression, agitation. Anti-epileptic drugs can affect cognition. Those can also increase feelings of depression and irritability. Chemotherapy. Chemotherapy side effects, people talk about having chemo brain. Chemo can lead to feeling fuzzy or having fuzzy thinking, difficulty focusing, and some memory loss. Immunotherapy can also affect the ability to think and plan, and other medications that can affect thinking and behavior can include things like pain medications, other medicines that manage depression, sleep, and anxiety. Now, some people will have changes in thinking, behavior, and personality because they're having a reaction to having a serious illness. You walk in the room and make the statement that you have a brain tumor, and that right there can cause problems with depression, problems with concentration, with attention. It can cause them in the caregiver, much less in the patient. This is normally called something called attentional fatigue, and what it does is it interferes with remembering and understanding new information, and it basically means that you are so tired and mentally tired that you can't pay attention. And the problem with this is that if you have this attentional fatigue, then you can have problems when you do go to the doctor with remembering what the healthcare provider said. You know, what exact treatment did they recommend? How long was it going to be? What were the side effects going to be? And that's why we always suggest people to write everything down. And when I work with people, I suggest that they bring someone with them whose only job is to write things down, so that the couple, the caregiver and the patient, can listen to what the doctor's saying and not have to worry about trying to remember it. Just listen and process, and that helps generate questions, while the third person can be in charge of writing everything down. So other things that can cause problems with thinking, behavior, and personality include age. If the person has a history of prior mood disorder, and damage to other areas of the brain. So those are all things that can cause some difficulty there. So what I'm going to do is just talk about descriptions and causes for these 4 things, and then we'll talk about some of the things that you can do to help with them. So the second most distressing symptom for caregivers is nausea and vomiting. And caregivers talk about it as feeling queasy and upset stomach. Sometimes it's related to food or smells or situations like cancer treatment. And there's such a thing as walking into the cancer center and feeling sick. There could be a bitter taste or an acidic taste in the mouth or a stomach fullness while eating. Sometimes being nauseous is actually worse than vomiting. Nausea can also increase the amount of saliva that you have. It can cause you to feel lightheaded or dizzy, have difficulty swallowing, changes in skin temperature and a fast heart rate, and a loss of appetite. So what causes this in neuro-oncology? Well, many things, as we pretty much say for everything. And nausea and vomiting can be caused by or triggered by specific areas of the brain or certain parts of the GI tract, certain parts of the gut. So there are nausea and vomiting centers in your brain. And if the tumor happens to be pressing on one or the radiation builds up scarring in that area, then that can cause nausea and vomiting. Vomiting is more likely to happen if the tumor is in the back of the head because it's right, depending on how much neuroanatomy you get into, it's right at the bottom of the 4th ventricle. One thing that you want to be careful of is if the patient is lying down and then wakes up, stands up, and vomits, and then is completely fine, you want to give your neuro-oncologist a call. And the reason for that is that there may be some blockage to the fluid that flows around the head. Chemotherapy is another thing that causes quite a bit of nausea. Vomiting is a lot less common than it used to be, but we still do have chemo drugs out there that cause nausea and vomiting, and some of those include Temodar, BCNU, carboplatin, Cytoxan, and Eranican. So different people experience different levels of nausea and vomiting, even after receiving the same chemotherapy, and that's an important point to remember, is just because you had a patient who had this terrible problem with nausea and vomiting or no problem with nausea and vomiting does not mean that the next patient is going to be the same. There are different types of nausea and vomiting. One is called acute, and that occurs within 24 hours of receiving chemo. Delayed nausea and vomiting is after 24 hours of getting chemo and lasts for several days. And there's also something called anticipatory nausea and vomiting, which occurs before chemo is given. And it's most likely to occur when we haven't been controlling the acute or the delayed nausea well enough. Now, radiation therapy is not as common a cause for nausea and vomiting. It can cause some from swelling in the brain, but really is not that big of a problem. Severe constipation, seizure medication, pain, depression, illness, and anxiety are probably much more common causes than radiation is for nausea and vomiting. Okay. Our third symptom is fatigue. And people describe fatigue as excessive exhaustion, kind of like when you're doing a 60-minute webinar, feeling weak or worn out, feeling heaviness in the body, and it affects a lot of aspects of your loved one's life. Now, these are all care recipient or patient symptoms that we're talking about. Caregivers may say that the patient has less energy, less strength, less motivation, lack of interest in work or friends and normal activities, and that's pretty common. Problems concentrating, the need to sleep more than usual, but not feeling rested after they do sleep, and less interest in their personal appearance. What causes fatigue? The tumor itself can cause fatigue, particularly if the tumor is on the right side of the brain. Chemo, especially Temodar, carboplatin, can cause fatigue. Radiation actually can cause a condition called somnolence syndrome, and that's a syndrome where you have extreme fatigue, drowsiness, and flu-like symptoms. And when you combine chemo and radiation, this can make fatigue much, much worse. Anti-seizure medicines can cause fatigue and other problems that the person has, such as sleep problems, depression, anxiety and worry, pain, not getting enough physical activity, low blood counts, anemia, not eating the right foods, or other kind of chronic medical conditions, things like high blood pressure or diabetes. And the last issue that we'll start talking about, and then we'll go back and talk about how to manage some of these problems, is a lot of caregivers talk to us about we need help with financial, legal, and advanced planning. This is a big issue for us, and we need a lot of help trying to figure out just what do you do. I'm going to second because I want to make sure that I'm giving you the right the right information here. So under this financial kind of milieu of everything that has to do with money, there are a lot of financial issues that people with brain tumors face and their family members. So we're talking about being underinsured or uninsured. Actually, the amount of coverage you get for being uninsured can sometimes be more than what you get for being underinsured. Eligibility for Medicare and Medicaid, needing help with medical debt, negotiating medical bills, organizing plans for payments, getting financial assistance with medications and with treatments, and keeping insurance coverage, things like COBRA and those kinds of plans that help maintain insurance coverage after employment ends. Some of the work issues that people talk about are having to do reduced or changed hours, reassigned duties, a loss of job or forced into early retirement, getting in trouble with their supervisor, being denied health insurance or retirement benefits, using up all their paid and unpaid time off, and difficulty applying for and trying to obtain benefits through government programs. We talked a little bit about that at the beginning. Okay, so let's take a look and see what we can do about changes in thinking, behavior, and personality. So we'll kind of go back through these four and see what we can do. First of all, when we talk to caregivers, we talk about them with how can you prevent and manage the problems. And it's really important that they are able to prevent and manage problems, but that they believe in themselves that they can manage the problems. That's one thing that is really important. So first of all, the first tip is to, with your loved one, eat as healthy a diet as possible. And my guess is that you didn't think I was going to say that. But that's one thing that can really help with behavior problems and with thinking and personality. Get as much regular physical activity or exercise as that person can handle. Take your medications as prescribed, and most caregivers are excellent about being able to manage medications and side effects and really don't need a lot of help from us. They have, in fact, most caregivers have books of exactly when everything is supposed to happen. Manage your other symptoms. Probably one of the biggest things is taking a minute to make sure that you have a safe environment. And that includes things like looking for possible fire hazards. If your loved one is no longer able to drive, keeping the car keys in a safe place. Avoiding dangerous activities like cooking or using power tools. Storing medication and alcohol in a safe place. Taking anger seriously. And a lot of times we will ask caregivers to keep a diary or a log, and that's something that you'll hear me say about each one of these. And one of the things that we have them do is identify potential triggers and causes of behaviors. And those are triggers, anything that sets off a specific behavior. Write down when the behavior took place, note the time and place, what was going on at the time, what exactly happened, and what was the outcome. And those are things that can help the primary care provider or the oncology provider figure out what's going on. Consulting with a neuropsychologist is also a good idea. Neuropsychologist is a psychologist that specializes in brain function, and they can offer suggestions about ways to compensate for problems in different areas of the brain. Other types of therapy that can help the care recipient include speech and language, psychotherapy, including things like relaxation or problem-solving therapy, occupational therapy, and physical therapy. So we really recommend a multidisciplinary approach. And that includes medicines that can be prescribed to help behavior, including things like Ritalin, which can help with focus and attention, and modafinil, which can help to improve cognitive function, mood, and fatigue. Social support. It often makes caregivers feel less stressed if they know that other people are going through the same thing that they are. Sometimes it makes caregivers feel more stressed to go to those social support groups. So you kind of have to take an inventory of how the caregiver feels about that, because some people really like it and some people really don't. Pushing my button and nothing's happening, so we'll try clicking. Okay. So what can you do about nausea and vomiting? Well, the first thing in terms of chemotherapy-related nausea and vomiting, like we said, they have the medications that they have for chemo nausea are so much better than they ever were. They can prevent vomiting, reduce nausea. They are probably best when used before chemotherapy, but some people can still have problems with nausea and vomiting even when they take these medications. So some of the things that can be prescribed is medication along with complementary therapies. So some of the complementary therapies that can be helpful, taking ginger, acupuncture or acupressure, relaxation techniques, exercise, hypnosis, music therapy. When the person is eating, we suggest that they eat things that are easy to digest, like toast or yogurt, hot cereals. We also avoid eating a meal in a room that's too warm. We also encourage people to drink a lot of non-alcoholic fluid each day, to slowly sip throughout the day to keep hydrated, and to breathe through the mouth and slow down breathing if they are feeling nauseous. Okay, financial and legal issues we talked about several times throughout this, so I'm going to make this part a little bit quick. So the first thing to do is help people understand what all their different options are. What is Medicare? What is Medicaid? What is Social Security? When are you eligible for different things? When you're looking at financial issues, we suggest that people make a financial plan, plan for out-of-pocket expenses, be aware of the range of cost, and estimate a little bit higher if they're not sure what it is. People need to plan for travel costs, hospital stays, prescription drugs, lost income, home health care costs, and home services. Now, if people do have bills, we suggest that they negotiate the bill, that they talk to the insurance, either the insurance company or the provider, about either lowering the bill because of reduced insurance coverage or negotiating a bill plan. Providers often will accept a lower amount of payment than the standard, what they'll tell you at first, but you have to ask for the discount. Under financial management, we suggest that people establish a filing system and insurance policy information, that they keep copies of everything, including dates and names, detailed written record of everyone that they've talked to, obtain itemized copies of bills, request an insurance case manager, and look at expenses. When we look at work, there are really two things that are very important about work, and one of those is being able to talk to your supervisor. Now, that's easy for some people and not easy for others. So talking to your supervisor is the first. Well, I'll say three here. Number 2 is knowing your human resources policies. So we really focus on helping caregivers understand and read through what they're entitled to through their job and what they're not entitled to. And the last thing is getting an attorney. If they start having problems, getting an attorney to help kind of control and take their stand and talk about it so that they don't have to. So finally, we're going to talk about fatigue and that up there, and how to manage it. And a lot of this focuses on exercise as well as diary. So again, keeping a diary too. Are there patterns to fatigue during the day? Are you more tired in the morning or in the afternoon or in the evening? There is a ton of research that has shown that physical activity is good for fatigue. And so if you can get 20 minutes of walking 3 to 5 times a week, that can really help reduce cancer-related fatigue. You have to talk to the neuro-oncologist to make sure that it's okay, and also be wary of any lower extremity weakness so that it's safe. But this can really help. Energy conservation, and that includes prioritizing. So what are the most important activities to do? Planning, pacing, and pacing includes stopping and resting during activities, and positioning. So positioning yourself in a way that is most comfortable for you. So to wrap up, those are 4 of the most commonly distressing symptoms that caregivers talk to us about. And I have here I put this back on the introductory slide because I welcome any comments, and I hope that you have enjoyed the webinar, and we hope that it helps you to help caregivers care.